Hello, everyone. I'm Singh. I'm a fourth-year medical student at the University of Michigan in Ann Arbor, Michigan, in the U.S. And I'm here to tell you about a pilot study that I'm running with my mentor, Dr. Tejasvi, who's also here. I'll be speaking a little later today. And this study is titled "A Model for Implementing Teledermatology in Remote Elder Care Facilities in Sri Lanka." And so I'll start by giving a little context as to what the problem we're addressing is, as well as our proposed solution with this project. So worldwide, there's a shortage of dermatologists, and the dermatologists that are there's a urban skew of the distribution of where they practice. And so this leads to a lot of gaps in coverage, especially in rural areas, as well as remote regions away from large cities. This disparity is worse in poorer countries, and so that kind of emphasizes that there's a need to fill this gap in the coverage. And one particular population that often is overlooked are residents of elder care facilities. These facilities are really important because they take care of the elderly population that can't live on their own, and they can often be located in all sorts of different sites. This population also has difficulty, even if there are dermatologists, traveling due to physical limitations of these patients often. And so taking all this together, we looked at trying to close the coverage gap for dermatology and using teledermatology as a solution for that. And our proposed solution is to create an access point within an elder care facility and do direct patient to dermatologist consultations. And so for this particular study, our setting is in an elder care facility / girls orphanage called Grace Care Center, which is located in Trincomalee, Sri Lanka. And on this map, Trincomalee is over here in the northeast corner of the country. And the nearest dermatologist is in the capital, which is Colombo, which is over here in the southwest, which is about 500 miles away. And so this site was chosen due to an established relationship that I had with the person who funds it and runs the site. He's a gastroenterologist also in Michigan, and also due to the fact that they don't have any dermatology care nearby. This location does have access to a primary care physician who does provide the care for the residents there. So in order to create this access point, we try to create a sort of simple, replicable model that could be used in other sites. And so it came down to creating a standardized history in physical form and using a digital camera to capture the images, having an internet connection, and using a cloud-based electronic health record called Enki. It could have been any sort of electronic health record we used for transferring the patient information, but we chose this one because they already used it at this site to track the general health care of the population. So the crux, though, of our model of creating an access point in the facility is leveraging what's already there to generate the teledermatology consults. And so particularly, that's relying on the in-facility medical assistants who take care of the normal day-to-day medications and health concerns of the residents. So we train them to fill out our consult forms and do the telederm consults. And additionally, creating relationships with the local primary care physicians, because those were going to be the physicians who carried out the management of our recommendations. So this is a visual diagram of how we have the information flow. So the cases and the patients are at Grace Care Center, and the medical assistants generate the consults and put in the electronic medical record, and then we get pinged sort of by the internal messaging system there that there's a new case, and we fill it out and send it back. And the sort of medical assistants and caretakers are really the kind of key people who then can take the elders to their primary care physicians and sort of bring our recommendations along there. Also, in terms of information flow, it's nice because this population is sort of a stable population that we have kind of consistent communication with. So we use like Skype and other teleconferencing in case there's any additional questions that have to be answered, or in case we have further requests like retaking pictures or anything like that. But primarily, we only access this if there's sort of additional work that needs to be done in the case. Otherwise, we can just kind of go through the electronic medical record, and that works pretty smoothly. So this study is currently ongoing, but the results up to now is we have the access point up and running, and we've trained the personnel over there. We've gotten a total of 5 cases. There's about 35 elders that live there. So now I'll just give you 2 examples of cases that we've gotten and how I think this service has sort of provided better results for the patients over there. So this first case is a 48-year-old lady who's had this rash on her feet for the past 2 years, and she describes it as itchy, it's bled at various points, and the obvious sort of color change for her was concerning. She actually already had a diagnosis of contact dermatitis of her feet, which was given to her by her primary care physician, and it was sort of thought to be due to the types of sandals they wear over there. In this part of the world, they often use rubber sandals, and the rubber is recycled from tire rubber, and so that can often lead to a contact dermatitis. And so, so they had changed her sandals, and they had what we felt was the correct diagnosis, but the problem was is they were treating the inflammation with hydrocortisone. And so that's where we could step in and say, no, we think you should, we recommend they use something like clobetasol, high potency topical steroid, whatever you have available in order to treat that. And so this kind of highlights that, it's not, in our situation, it's not like they don't have care, but having the additional specialty knowledge and comfort using, various levels of the topical steroids sort of added to this patient's care. And so I apologize for the blurriness of this photo, but this is the right thumb of a 51-year-old lady who's had this discolored thumb for about 24 years. She said that she remembered about 24 years ago she may have had some trauma to the thumb, and it sort of became lightly black. And 3 years ago, she remembered she had a surgery on the thumb, although she doesn't know what it was for. And after that, it became this sort of dark black. At the time, 3 years ago, she was treated with dactylorine tincture, which is an antifungal, and it didn't really improve it. And so now that the service is available, she wanted to get another opinion on this. And so, looking at this thumb, we came up with our differential and said that, we can't give you an exact diagnosis, but, could this possibly be trauma versus fungal melanonychia or versus true melanonychia? And so we recommended in this case that, you should go and get it reevaluated in person with a possibility for a biopsy. It's, been there for a very, very long amount of time. And so in this case, we couldn't provide an exact diagnosis, but we were able to sort of assist with the next steps in management and what sort of should be done going forward. So like I said, we've had 5 cases. We've actually had a lot of contact dermatitis. That's been the majority of our cases at this point. Also a case of pitted keratolysis. And so I'll just sort of end by talking a little bit about some of the challenges of setting up an in-facility access point. So originally, we had this up for a number of weeks into months, and we were not getting any cases. And so we had to sort of troubleshoot, what the issue was. We had done the training in terms of the medical assistants, how to take the pictures, how to upload and all that. But it turned out that the problem was they didn't know what was an appropriate case for a dermatology consult. And so, we had at the beginning told them, any skin concerns or nail concerns or hair concerns, but it wasn't quite enough to sort of get across, that they could consult us for something where they are being treated like the contact dermatitis of the feet, but weren't getting the adequate results. And so we sort of took a step back and made a presentation to them about common dermatoses and hair and nail conditions that are in that part of the world. And after that, they sort of got the idea of, oh, okay, these are the appropriate types of cases to send to the dermatology consult service. There was a bit of a language barrier. They speak Tamil is the language that they speak over there, and so this challenge was mostly felt in terms of getting the history, because the medical assistants over there, most of them are bilingual, so that wasn't really an issue. But having several layers of translation, especially into sort of medical English, is where sometimes there was a little difficulty there. And then connecting with the local providers was something that we were lucky that we were fortunate to be able to get it done with the ease that we had because of the established relationship with our location. But that's a very, very important aspect, because we're so remote. We're giving recommendations, but we're not going to be carrying out the management of the care of the patients directly. And then two other things which I have in blue here are just kind of thinking about if you're trying to apply this model to another site, and we had an EHR, but setting up something to securely transfer the patient info sort of in a safe and, depending on the location, HIPAA-compliant manner is something that is an important thing to plan out when you're making a decision to go down this route. And finally, if you're trying to think about using this as a model in a practice, then payment issues will obviously be something that has to be taken into account, whether that's knowing the local insurance laws and how you can do reimbursement. So, so last slide, just in conclusion. So, the study's ongoing, but we've already shown that it is feasible to set up a very low-cost teledermatology access point where you can provide direct care in an elder care facility. It's important to educate your kind of on-the-ground personnel about what cases are suitable for teledermatology consults, and specific adaptations of this model would require connecting with local providers, knowing local insurance laws, and how you would in order to implement it into a practice where you're charging payments as opposed to just doing research. And in the future, though, we sort of envision that we can package the various aspects of this technology, whether it's the digital camera or access to the electronic medical record, as well as the access to the dermatologist, into sort of kits that can be, given or sold to elder care facilities, and have that as an easy way for them to add a package of teledermatology care to the care they're providing for the elders there. So that's all. Thank you.